Well, good afternoon, everyone. Welcome to Wayne State University School of Medicine's fourth annual Medical Education Research and Innovation Conference. It is a pleasure to have everyone here today. We have two wonderful speakers with us today. Plus, we have a large number of student posters, along with faculty and staff posters and oral presentations as well. Before we get started today, I'd just like to talk a little bit about this conference and its importance both here at Wayne State University School of Medicine, but also how we feel that it serves as a good template or role model nationally. This conference was purposely created over 4 years ago to do several things. One, and most importantly, is to acknowledge the current curricular innovations that take place here at the school by providing participants a venue to showcase their work. Second, this conference was created to also help individuals take their works in progress to completed projects or innovations. Third is to help individuals take their research from the local stage to the national stage. And finally, to help individuals translate their either posters or all abstracts into publications. I guarantee that this will be a very exciting conference for everyone today. There's a few housekeeping items that we would like everybody to keep in mind. We ask that all participants stay muted throughout the event. Second, to ask them to keep their videos off during the event as well. Please, though, ask your questions in the chat box throughout the event. We are here to both receive and give feedback throughout. And then make sure your names are shown correctly in the Zoom window. This way, when we have opportunity for interactions, we know that we are highlighting the correct individuals. With that, I would like to now turn it over to Dean Sacher.
Well, thank you, Jason. Appreciate this opening for a great conference. And I would second your welcome to our two distinguished keynote speakers, along with everyone else who is joining this program. As someone who has been at Wayne State University for a long time, this is my first time attending and presiding as a dean in the proceeding of such a conference. I tell you, the research and innovations and the high impact of our clinical, basic, and community-based research in Wayne State University School of Medicine have always been, I think, very impressive. Many of these, due to my long term here, 32 years at the university, are personally familiar to me. To cite some examples that are not limited to our immediate surroundings, some of you in the field of oncology may remember a nasopharyngeal carcinoma that is a common disease in multiple areas of the world, being a difficult to treat disease. The combination of cisplatin and radiation therapy for that disease in two randomized arms ended up closing the trials quickly, much faster than planned to, because the double treatment arm proved to be highly superior in treating and curing this disease compared to either one of the modalities. The medical oncologist was here, right here at Wayne State University. In my earlier junior career here, I got to know a Jerome Hirowitz, who was one of the pioneers in virology and many of the immunologic diseases. Jerome Hirowitz was the first individual to introduce AZT as the treatment of AIDS at the time. There are many other examples that we can cite. In addition to both translational and basic research innovation at Wayne State University. I would also submit to the audience a fact that is known to most of them. With our location in the heart of the city of Detroit and Wayne County, where significant health disparities, mostly racial and ethnic related, with respect to a number of health metrics. The protocols, the innovation, the interventions that Wayne State Medical School research led to improve these conditions is one of our very certified strength. And if any, we are moving stronger and stronger in that directions and expanding our partnership towards a more meaningful and impactful community-based research. So from our immediate background in our surroundings, in the city, in the county, to a global impact, Wayne State University research stands as very distinguished and makes us very proud, and if any, motivates all of us to invest more energy and resources in it. So I'm very excited to introduce the conference to you, and hopefully we will have a great afternoon with both our speakers and the multiple contributions of our students and faculty and staff to this endeavor. Thank you, Jason, and back to you.
Thank you, Dean Sacher. With that, I would like to now introduce Dr. Diane Levine.
Hello, everyone. It's my pleasure to be here with you virtually today. I'm going to ask if everyone could please say hello in the chat. And while you do that, I have the great pleasure of introducing our first keynote speaker. Our keynote speaker is Dr. Catherine Chrétien. Dr. Chrétien is simply amazing. I have known her for many years, and I will read you her bio and supplement to tell you some of the amazing things that she does. But currently, she is the Associate Dean for Medical Student Affairs and Director of Medical Student Wellness at the Johns Hopkins University School of Medicine and a hospitalist physician at Johns Hopkins Hospital. Prior to coming to Johns Hopkins in these roles in 2021, Catherine was the Associate Dean for Student Affairs and a Professor of Medicine at George Washington University School of Medicine and Health Sciences, where she served as a Career Advisory Dean, oversaw the Office of Financial Aid and Scholarly Concentration Program. And all the while, she worked clinically as a hospitalist at the Washington, D.C. Veterans Affairs Medical Center. And she did so for 18 years, where she was also the clerkship director, the site director for the George Washington site. And she was the first division chief for hospital medicine from 2010 to 2016. I met her when she served as a clerkship director member, and then she became the president of the clerkship directors of internal medicine from 2019 to 2020. And she's currently the Northeast Group on Student Affairs representative to the AAC's Committee on Student Affairs and a chair of the AAMC Medical Student Civic Advocacy Work Group. But I will tell you how I met her. She was a member or in the lead of the Survey and Scholarship Committee at CDIM. Her work was creative and innovative. She's incredibly collaborative. And one of her skill sets is to reach her hand out and elevate and advise, mentor, and help everybody in their careers. That's what she did for me. She is an inspiring person. And she won the Charles H. Griffith III Educational Research Award from the group. And that is an award that keeps giving. As part of that award, she had to do a review of all the medical education research and presented to the CDIM community. Her presentation was spectacular. She contacted every author to find out what their motivation was. And in so doing, she networked with outstanding researchers and innovators, but her presentation was perfection. I don't think that you could hear anybody whisper a pin dropped and you would hear it. She also has received the Women Leaders in Medicine Award from the American Medical Students Association. Her background, she graduated from Brown University before attending Johns Hopkins University School of Medicine, where she graduated AOA, no surprise there. She completed her training in internal medicine also at Johns Hopkins, and she's come back to roost, so to speak. Her area of academic focus has been on social media and medicine, medical education, narrative medicine, and well-being. And she is the editor of several books, Mothers in Medicine, Career Practice and Life Lessons Learned, and the author of the book, I wish I read this book before medical school. And I did go to Amazon, where it has uniformly received 5 stars. So we are so excited to have you here, Kathy. And if you would please begin, the title of her presentation is 3 Stories, 3 Studies. Thank you.
Okay, great. Well, thank you so much, Diane. That was such a kind introduction. I will share my screen now. And by the way, the Amazon reviews, I think there's only 3 of them. So I will share. So it's such an honor to be here today with this conference. I am such a fan of medical education, research, and innovation, and so honored to be here talking with you today. I also wanted to give a shout out to Diane Levine, who is inspiration in herself, and I have loved getting to know her, be a collaborator and colleague with her over the years. So you are very lucky at Wayne State to have Diane there. So I wanted to share my conflicts. I have no current conflicts to disclose. I was the student engagement lead at Aquifer, which is a nonprofit educational organization from 2017 to January of this year, and I received an annual honorarium for that work. So the title of my talk is 3 Stories and 3 Studies. I am a huge fan of storytelling and narrative medicine as a way to better understand our patients, to role model vulnerability with our learners, and to address imposter syndrome. There are so many ways to use stories in our lives as medical educators. And I thought when I could talk about anything today, that I wanted to focus on 3 stories of 3 studies that were very important to me. These are 3 studies that happened about 5 years apart during my career. And each of them really taught me a lot about medical education and research and innovation. And I thought were important pivotal points for me. So I would love to share my lessons learned, some of the failures, had plenty of failures, and really go through those stories for you one by one. So I'll start with story 1. You can just sit back and relax and listen to the stories. So this story takes place in the early my career at the Washington, D.C. VA hospital, where I started as a hospitalist right out of residency. So junior attending there and the medicine clerkship site director, as Dr. Levine shared. And while I was in that role, I noticed that students were really hungering for more physical exam teaching. They were unsure about their physical exams, and I felt like there was a need for something there. So I decided to start bedside diagnosis rounds, this is what I called them, to really emphasize physical diagnosis and the art of observation. Prior to every session, and what we do is weekly, we'd gather together as a big group, and then we'd split up into small groups of 3 or 4, and each group would have a faculty member or a chief resident go to the bedside of patients with salient findings. So I'd collect this beforehand, and we'd go and see the patients. And before we started, I always read a quote from Osler. I am from Hopkins, so that was as required as part of your contract. So I shared something from my book of the quotable Osler, like this quote you see here, and he was the patron saint of our bedside diagnosis rounds. So with a rousing quote, we would go and see the patients, and each time we'd go and I'd go in first, make sure it's okay with the patient, and then if it's all right, we'd bring in the students and we would really observe them, see what the students could pick up just with observation alone. And sometimes they're blown away by what they could pick up with that. And then we would do focused physical exams, make sure everyone heard the murmur, everyone felt the liver, if applicable, and then we'd step outside and talk about the patient and do some teaching. So one day we were doing this, and right after, we were outside the room after a good session, and one of my students said, I always feel badly learning from patients at bedside diagnosis rounds, like I'm taking advantage of them. I wonder how they feel about it. At that time, I thought, that is a great question. I don't know if that's ever been looked at. I wonder if it has, and if not, maybe we should. So that was the start of an idea of this study. And we looked to the literature, did not find anything related to the patient experience undergoing physical diagnosis rounds. There was the side of the teachers, but not of the patient. At the same time, I just happened to be in a year-long professional development course at GW. It was called the Master Teacher Leadership and Development course. And that was a year-long program where I spent 1/2 day a week taking graduate level courses for teaching and leadership. So courses like adult learning theory and organizational change, leadership, and qualitative research. So I was in a qualitative research class at the time. And this is one of the things I learned about this specific study, was the importance of that extra training to provide more opportunities for you to grasp and start a study on. But my course was on qualitative research, and I thought this would be a great qualitative research question. In particular, I learned about one of the frameworks of qualitative research, which is phenomenology, which is really studying the meaning or essence of an experience for human beings. And the question would be, what is the meaning of physical exam teaching for patients? Now, I presented this to my instructor, who was really wonderful, and she agreed to guide me through this study, which was really key because I had never done it before. I had no idea how to approach the work or the research or coding, nothing like that, interviewing skills, etc. And so she agreed to take this on with me. So it was myself, Ellen, my instructor, qualitative researcher, the student, Katie, and also my mentor at the VA, Charles Vaselis. So that was our study team. And we looked at this. We did in-depth one-on-one interviews with patients who underwent this experience to find out what was it like for them? What was the meaning for them? One of the things I realized was that coding is not for the faint of heart, and qualitative research is tough. We had piles of transcripts. This is not the actual transcript. This is just an example, but we had piles of transcripts, and our data was the words and coding them, and we did it manually. So it was my instructor and myself on one Saturday. We spent the entire day coding, discussing, and trying to come up with the findings from the study. And so that was one of the things that I appreciated from this. And this is what we found. We found that there were 4 main meanings for patients undergoing physical exam teaching. And they are abbreviated as, the T stands for tolerant. So some patients were tolerant of the experience. They understood this happens in a teaching institution. It doesn't bother me. They agreed to participate, but they didn't get anything out of it. It was just, okay, I'll tolerate it. And probably if it lasted too long, they'd want it to stop. The other meaning it could have was a helper. That's the H. So these were patients who felt a sense of altruism by teaching medical students. In fact, they felt they were doing a service, maybe in the service, because these are all veterans. Maybe they were instructors or did something related to teaching, and they felt good about that. So they had a good sense of helping. The L stands for learners. So some learned during the process and they felt empowered by that learning. So, wow, I did not know that the sounds that makes on my stomach is fluid. And they got to understand more about their own disease processes in the teaching, and they felt empowered by that. So those were the learning meaning. And finally, S stands for social. So these are the patients that had been there for a long time. Maybe they're completing antibiotic courses and they were bored, and this was the highlight of their day. So they lit up talking about it. They said, oh, it was so great. The students came in and we talked and I made them laugh. And this was seriously a wonderful social moment for them. Interestingly, we found that the interaction of physical exam teaching could change people's meanings. So they could start as a tolerant patient and move to a helper by what we did, or a learner, or social during the interaction. So we had some patients that moved from one to another by the end of the session just because of what the teachers and the students did. And we also saw there was individual factors that played a role, including a person's past experience, their personal values, what kind of illness they had, and their health literacy level. So this was a study that was published in JGIM in 2010, and it was the first qualitative study that I had ever engaged in and published. And so what I took away from this study, some of the main takeaways, is study what you're doing already. You are doing really interesting work. You may be starting innovations in what you're doing in your teaching. And to study that, make sure that you are making things count twice. So if you're doing it, you're starting it, think about studying it. And that is a great starting point. Good questions are everywhere. So this question came up naturally in the course of a teaching session, but they're everywhere. And it's really thinking about these. And maybe if that time, you don't have the time to start that study right away with a good question, put it aside, write it down, and take it out when you do have that time, because these good questions are everywhere in what you're doing. I learned that qualitative research is really tough, but also so rich. I mean, being able to have these findings and put some meaning into these words and these experiences were really powerful. And so I really appreciated what qualitative research could do. I learned about the importance of a team, how important it was for various people on the team and have their expertise added to the study team. You cannot do it alone, and how important it is to have the people with the right skills and finding those people and adding them to the team. I could not have done this without Ellen, for example. And so that was really important for this. And finally, that professional development adds value. You know, it was that training, that opportunity, and maybe it's not a year-long course that you're doing. Maybe it's a conference that you attend or a one-day session, but thinking about what your needs are as a medical educator, researcher, an innovator, and what additional skills you could use. Being an adult learner in that class was wonderful. I had so many ideas that entire year of new studies I could do, of new interventions I could have within the clerkship. It was a time of great creative output. So even though it was a lot to balance that year, I was, having a full days at work, but also doing this homework on the side. I loved it, and it was learning and growing and enriching and very different going to school when you have a purpose for it and you can apply it immediately to your work. So on to story 2. And story 2 takes place about 5 years later. And I need to give a preface, and involves blogging. So back in the day, and this was around 2005-ish, 2008-ish, everyone had a blog. I don't know if anyone on this call had a blog, but lots of people had a blog at that time. And I had a personal blog that I started. I started it because I really want to capture all the amazing moments that were happening with my daughter. This is my first child, and I want to capture it and write. So I'd write almost every day, and it became a really important part of my life of writing and sharing in a community of bloggers. So I had this whole community where we would visit each other's blogs and write comments, and we would support each other. And it became a very important community for me. One thing led to another, writing on this, getting networks, and improving my writing in the process, that I started to get these other side blogging jobs. So this was one called Momacillin, Take As Needed. And I was one of the bloggers for this newsletter that went to people's mailboxes, inboxes. And so I got experience writing a lot, blogging on multiple group blogs, and also blogged for Disney at one point. I also used blogs in my medicine clerkship. So I really wanted to be able to capture those salient moments that happen in a medicine clerkship to students that they might not have an outlet to write about or to talk about, and piloted a reflective writing blog for the clerkship where they could write about really important things as they happened. And then other students would read and write comments, and I would read and write comments, and we were trying to get deeper in our reflections instead of brought blogs into my work as well. And then started a group blog for Mothers in Medicine. With all this blogs going on, I thought a big hole at the time was having a place to write about motherhood that I felt I didn't always have as a junior faculty member, and wanted to grow a community around Mothers in Medicine. So this was the kind of the backdrop of thinking about social media and writing as a doctor, and what are the different complicating factors that play into that. For instance, there's lots of doctor blogs, and many blogs would, maybe make fun of patients or something where it was questionable about, wow, is this professional, and how much is this happening? And thinking about questions related to professionalism and social media. Naturally, because this was the space that I inhabited. I also joined Twitter. No comments about how Twitter is doing right now, but I was part of Twitter since 2009 and also there in that space. And this led the backdrop for a number of studies. So I started to have some questions about social media and professionalism, and started to follow that in my academic work. And one of the first questions was, what have medical schools seen in terms of students posting unprofessional content online? This was a big question that came up because I'd heard that students were sometimes getting dismissed from medical school for things that they posted online. So I wanted to capture what is happening out there. This was 2008, 2009, where we weren't really sure what was happening. Were there policies that supported this, and what kind of education was being provided around this if people were getting dismissed? So this was a survey that went out on the listserv for the Group on Student Affairs and the AAMC. And after that, a number of studies came to follow after that was published. Things that naturally followed from the other questions: what policies do exist? So looking at all the policies on the different medical school websites. And how is unprofessional content defined by various groups? And thinking about medical educators, students, state medical boards, and patients and the public. Of note, that last topic, patients and the public, was something that was really important to me. I wanted to make sure we captured what the public thought about this, and note that publication happened in 2020. It took many, many years. That was one of the stories I won't tell today, but involved a lot of grit, perseverance, and eternal hope. So eventually that got published. How are physicians using Twitter? Twitter, had come on the rise. I was seeing what was happening there, and we did a descriptive study on that, and also how to teach it. And so describing the educational innovation of teaching social media professionalism at GW. So the question that arose at that time, and the subject of this next story, is one of the students said to me and my partner that did a lot of this work together, Terry Kind, what are medical students getting from Twitter anyway? And they were noting that there was many medical students on Twitter using it seemingly for their own professional development. And we wanted to better understand how that was happening, what was happening, and what are they getting out of it? So that sounded like a qualitative study. So as we thought about that, we were wondering, what was the approach? It's not a phenomenology where we're trying to get the essence of an experience. We wanted to know more, like, who are these students? Like, who are they? What are they getting from this? How are they using it? What are their networks? So what we're really trying to get at is an ethnography, which is a study of a culture. So we wanted to study this subculture of medical students who are using Twitter for their own professional development. You might have heard about ethnographies with anthropologists out some culture, trying to study it, looking at artifacts, doing observations over time, writing field notes, doing interviews. But how to do this on Twitter was the big question. So the idea for the study arose, thinking like, how do we possibly put this together? This is what we want to do. How do we get there? And unfortunately, it wasn't a straight road. It wasn't something that, like my first study that I mentioned in Story, where someone knew exactly how to do it and took me step by step through a very specific process of phenomenology. This time, we're thinking about an ethnography in this digital space that wasn't a well-traveled route. In fact, it felt like this. It felt like we didn't know exactly what we were doing and trying to extrapolate various studies in the literature that looked at social networks and other ethnographies and trying to make it into a solid, rigorous study that we would find the answers to the questions we were looking for. So we settled on these methods. So for a digital ethnography, we were going to do a content analysis of tweets, and we identified a set of 31 medical students on Twitter that we agreed were kind of super users using Twitter to for their own professional development. So they were sometimes quizzing each other with various questions. They were interacting with mentors. They were sharing information related to education, and they were networking. So we did a 8-month tweet content analysis of these 31 students on Twitter. We also picked out 10 to be key informants and did in-depth interviews one-on-one. And this last bit was a network analysis. So we really needed to understand how they were connected online with other people and what were their networks like. And that was the biggest gray area, because I didn't really know how to do that or what that looks like or any of the terms related to that. So that was a huge challenge. I looked to the literature, looked to see who might be doing something similar. And I found a computer scientist at Georgetown just down the street who had published something related to network analysis. So I cold emailed her, totally did not know her at all, and just asked her if we could meet and talk about potentially being part of our study team and what we wanted to do. And I ended up having coffee with this random stranger who was at Georgetown, and she agreed to be part of the study. And so that was really a big, important part of our study, is finding the right expertise to fill in the gaps of things that we did not know. And these are examples of some diagrams and figures that she created for us with the data, and she downloaded all the data of our key informants, Twitter posts and connections. So on the left, it's the full followers network of our key informants, our 10 key informants. And the size and color of the node corresponds to the degree of the node, which is the number of connections. The 10 key informants connected to 40,000 individuals, which was pretty amazing. And on the right is our key informant network and all of their connections together. And there are ways to describe all of these nodes and how they were connected. And we were able to describe that this was really this was a social network instead of an information network, and absolutely could not have done this without the help of Lisa Singh. So very grateful for her help here. As we analyzed the interviews and looked at the content analysis, we found that students were using Twitter as a professional tool, and it gave them two main values. And one was access, and access to many different things, including opportunities, perspectives, community support, and mentorship. And it was giving them voice. They're allowing them to advocate, to have control over their digital footprint, and to be an equalizer. They were saying, I'm able to reach out to attendings, and I feel equal in that, and it really levels the playing field for them. So this was a study. It was a digital ethnography of medical students who use Twitter for professional development, also in the journal General Internal Medicine. I have to say, this is a journal that became a home for many of my studies, and I felt very comfortable submitting things there and presenting at SJM and getting connected with that whole community. And importantly, the team members included Matthew Tuck, who I helped mentor through this, Michael Simon, who was a student who asked the question, Lisa Singh, who is the computer scientist, and Terry Kind, who was my partner in crime in all this. So one of the studies where I also felt like I learned a lot. Still, good questions are everywhere, asked all the time, and to pay attention about that. Again, about qualitative research, it was really hard yet again, but so rich in our findings and what we're able to determine about this culture. The importance of the team, again, so important that these expertise areas were represented and everyone brought something different, and how important it is to make sure you have a full team that can fulfill all the needs that you have, especially with qualitative research where you need to have usually 2 people at least doing coding, et cetera, and negotiating differences. And you do not need to be the expert. This was something I did not feel comfortable in. I did not know the area of network analysis, and that was okay. It's finding the people that can fill those gaps. And you find your path with creativity and thoughtfulness. So being able to charge ahead, even though you're not really sure about the next steps, but trying to do it in the most rigorous way possible. That's logical, that makes sense, and that reviewers will also agree with as well. So on to story 3, and this takes place also about 5 years after the last one. So if you're not familiar with Aquifer, I mentioned I was student engagement lead there for many years. It is a nonprofit educational organization that has virtual patient cases. And these are some of the core cases that they have in family medicine, pediatrics, geriatrics, radiology, and internal medicine. And there's other content as well. They were formed in 2006 and are used by 96% of US allopathic medical schools, which is really amazing. And to date, 15 million virtual patient cases have been completed. So there are many students using these cases over and over again, and really high impact. I joined as an associate editor for internal medicine. So I was responsible for a group of cases and made sure that they were updated, that they were still accurate, that negotiated any feedback around them. And I was doing that for several years. And just to give an example of what these cases are like, in case you don't know, it really takes a student through the entire care episode, including taking a history, doing the physical, coming up with differential, and coming up with diagnosis and treatment, and then managing. So it takes you through that whole process in a case. Now, Aquifer received some feedback over the years, and as they formed in 2006, we're talking about 10 years later, where we're getting feedback saying cases need to be updated. They're getting a little bit stale, and including that some were problematic regarding how they address race and culture. And they felt students were saying that they're out of date and they reinforce stereotypes, even though they didn't mean to. So that was some negative feedback that we really wanted to be able to address. So this story really starts at a Starbucks, and it was in 2016. This was in Seattle, and it was during the AAMC Learn Serve Lead meeting. And I remember it was November 2016, right after a very divisive election where many people were disappointed about the outcome and worried. And it was in that setting that I met with 2 people from Aquifer to think about what were the next steps of what we could do. And at the time, I was thinking that being an associate editor wasn't really fitting how my career had moved. I had moved into student affairs and being in the dean's office, and I really wanted to work more directly with students rather than making sure that these cases were up to date. And I was thinking about either changing what I did with them or perhaps finding other opportunities, because I really wanted to work with students more. And at this meeting at the Starbucks, we talked about really the importance of engaging students in these cases to reflect their ideas and help them create, and also to address some of these issues that were coming up. And importantly, we're thinking about race and culture. given the times and how important it was to make sure we were addressing it in the best possible way. And so at that meeting, we decided we would have a group of students join this project where we would look at how race and culture were represented in the cases. So the purpose was to engage medical students in developing an evidence-based checklist to evaluate clinical teaching cases, to improve the teaching of race and culture. And, starting with the idea of the Aquifer cases, but being broad enough to also apply to other teaching cases and be able to have a bigger reach than just these virtual patient cases. We saw that was a very important need throughout. Lots of schools were wondering how to do this and struggling with it. So our goal first was how to build a team, and we thought about how to do this. We'd have to do it virtually, and it would be a virtual team. So we had a call out nationally for students to join our project and got a lot of interested responses from passionate students who are working in the space already of curricular development and diversity, equity, and inclusion. They wanted to work on this, and it was really exciting. We selected a group of 4 students to join our team, and we're faced with the first huge challenge of starting a virtual team from scratch and having those kinds of connections that allow us to work well together, to build trust, and to have a good project come out of it. And that was really challenging. That was hard to get people together, even different time zones. We had one student that was on a year off in Thailand, and trying to coordinate these schedules and getting everyone together was one of our big challenges that we did and faced. So kind of to walk you through the project, we first assembled a team and then engaged the students in doing a literature review and development of an analytical framework that we could apply to the Aquifer cases. That took a bit of time, and it was challenging for me, especially as, I wanted to join and do this project to work with students and engage them, but I did not feel like an expert in the content area. I did not feel like an expert, even though I wanted to learn more. And that was very tough for me. I had to have lots of humility as I went through and admit that I did not know, I was not an expert, and I would rely on the expertise of others in this work. In the summer of 2017, we conducted a case review after developing this analytical framework to apply to every case and looked at the themes that resulted from that. In the fall of 2017, we made some preliminary recommendations, and at the annual Aquifer meeting, we did some stakeholder checking and made some revisions. So this is photos from our annual conference that fall, and on the right and the left, you'll see 2 students that were there representing the team. And one of the things that was challenging about this work was that we had 4 students, and by this time we had 2. And we had attrition. One student stopped, interacting with our team, and I was worried that maybe it was either the student felt like they either weren't included or didn't like where it was headed, but actually it turned out to be something personal that we found out later. Another student was applying that cycle and just got too busy to be able to continue. So it was difficult to continue this team going, but the 2 students we had remaining were just phenomenal. So this is them presenting our work and getting feedback and stakeholder checking on our recommendations. The educators that we presented to were wonderfully receptive, asked great questions, had good feedback that we incorporated. With their feedback, we created a 6-step guide that would help educators or reviewers go through their teaching cases and be able to make changes so that they reflected best practices. And I'll give you an example of what the guide looked like in the next slide. We also spent some time disseminating in the spring to follow at conferences, and were able to publish it as well. So this was an example of the guide And it would prompt reviewers to ask, does your case include any of these? And this is just from an example from section 2, which is about social structural determinants of health to understand patient behaviors, and using that to understand that versus attributing it to a patient's race or culture. So we would have suggested case edits, have examples, and also all the references and all the reasoning why we made those suggestions. And this was the end product, which was addressing race, culture, and structural inequality for medical education, with team members of students, our Aquifer staff member, Steve Scott, who was my partner, collaborator on this. And it was a great team. So the things I took away from this project was that learners add value always. And that was true for the other two as well, but this one especially became so prominent because it was the students who really drove this project. They added so much to every part of it. I was in awe, inspired, and they were so passionate throughout. So what they added, and I would say to any kind of educational innovation, can be invaluable. So incorporating learners into your projects is, I think, really great to consider. Humility is a virtue. I had lots of humility during this, feeling that I was not an expert and deferring to experts and developing expertise together. And so I think it's really important as a medical educator that you do not have to have expertise to guide a project through that is sound methodologically, and that can have a good product. So keeping that humility in whatever you do. The importance of a diverse team was really relevant to this team as well as all teams, and giving those diverse perspectives and how much each person contributed a different perspective to this. And the other two students that stopped participating did also contribute very importantly to the beginning and the framework and all those parts. After this project ended and those students graduated, we recruited a whole new set of students for the next phase of that project, and that was to apply all those changes to all the Aquifer cases. And so that was another great team to work with. Virtual teams doing research or education or innovation, they require extra care. It was difficult to get this team off the ground, bonded when you only meet online, and it took time. It took a staff member of really having regular meetings that we would touch base frequently, and I think that extra effort was really worth it in the outcome. And finally, to make it count twice, this was something we were going to do for the cases anyway, and to be able to translate it to help others broadly, that is the goal. So really taking what you're doing, what you're learning, and sharing it with others so they can learn from it or adapt it or grow from it, but really contributing to the medical education community with your work, as much as possible, and helping others do their work. That is the goal. So that's really the three studies that I wanted to talk about, and everything that I've learned. And over time as a medical educator, I never would have guessed that I would be doing this work over time, like as a medical student, definitely not. I never would have imagined that, or even as a resident. This is something that happened, later on organically, and really following my passions and seeing where that led. And I think that even if you're not really sure where you're headed, is to follow those passions and to think about these concepts and having, research of the teamwork of the diversity of listening to those questions that come up. What really excites you? What makes you want to do a study? That's different for all of us, but it's finding that and going with it, because having that passion and that drive will help you through all those hard parts of the studies that may come afterwards. So happy to take a breath there and stop and see if there's any questions that I can answer.
Great. Thank you so much, Dr. Chrétien. We enjoyed your talk and we have questions for you. I'm going to leave my questions for last so that everybody has an opportunity to pick your brain. So Tamia Robertson asked, how did the results of your qualitative research affect how you interacted with your patients or how you interact with your patients? Did you become more aware of the impact that you have on your patients in your day-to-day rounds?
That's a great question. Thank you so much for asking it. I absolutely changed the way that I did rounds, the bedside rounds, as well as shared it with others that were doing rounds to make sure that everyone knows that you can really affect how patients are experiencing this teaching. Like it can be a win-win for both parties. It doesn't have to be one-sided, where they feel included, that they learn more about themselves, that they feel altruism, that they're thanked. So something we would consistently do after that is, when we come into the room, it's to ask to introduce everyone, first of all, so that, the patient knows everyone who they're helping. And we'll say, here are all the people you're helping today. And then having students share their names and where they're from. And that sometimes would launch into, oh my gosh, I'm from there too. And having this connection and making these social bonds too, of including them in these conversations, including them in your teaching too, about, this is what this means. This is why we're looking at this. I remember one patient had said, there were two teams that came in. I think he was talking about an earlier team that had examined him on rounds versus the bedside teaching rounds. And he said, the first team came in, they had me look to the side and looked at my neck and then walked out while I was looking still to the side. And so like all the differences of what we can do to make it patient-centered education as possible.
Great, thank you. Dr. Apple has a question as well. He wants to know, how can the clerkship directors of internal medicine or any clerkship organization or group, here we are, engage in more collaborative studies across institutions? He comes from an oncology background, as you know, where collaboration is the norm in studies, the Southwest Oncology Group, the Eastern Oncology Group. And he's struck by the fact that most studies in medical education and innovation are single school studies. So do you have any thoughts about that?
I think that is a wonderful question. Thank you, Dr. Apple, for asking it. I did try at some point, I think many times in CDIM and in AIM, the Alliance for Academic Internal Medicine, is to create a network or some area where people could go looking for collaborators. And that was one thing that we tried to do, like to build a hub around that. I think that going to conferences and networking with people, seeing their posters is a way to connect with those interested in what you're interested in and trying to build studies off of that. So one example is when I presented at CDIM once about the blog, I'd met others who were thinking about it, but had a very traditional way of teaching about reflection in the clerkship. And we combined forces and did a study looking at randomizing students to either the blog or traditional ways in both of our institutions. So that was, a 2-institution study, but that really came from CDIM and that presenting. I think like presenting your work as much as you can, either posters or, in other oral presentations to share and then see who else is interested in that can be a great way to find others interested in that work and to expand. Because I think multi-institutional studies are great, even though they are much harder to coordinate and pull off, and they are a lot of work, which is why I think lots of times it is single institution. It's just a lot, easier. But yeah, more and more, and also listservs, medical education listservs, finding different collaborators that want to be part of this study and being very open, because often it's like who and inviting people versus being more open, a broad call, who's interested in this, who wants to be a site, and having it out there and then just getting people to collaborate who say yes.
So that dovetails with one of the things that I wanted to ask you about. You said that you reached out in a cold call to somebody who was at your university to ask them about the research study that you did analyzing the qualitative data in nodes and so forth. So can you give some advice to our participants here about how you approach someone you don't know, or even somebody who you might know casually, for mentorship or advice, because I think a lot of people are uncomfortable reaching out. My personal experience is that people are quite generous, but you shared a lot and shared your vulnerability at the beginning of your career. What can you share specifically for our participants?
Well, I was wondering, how do I find someone? Like I need to find someone with this skills, and I don't know anyone. And it was someone at it was a different institution in the undergrad, so it was not anyone that I had any connection to, but it was just an honest, you know, inquiry about, this is what I found you through this way. I saw you did this work. I'm doing this study, and really have no expertise in this area and looking for someone who can do that. Like, it was just very, brief and not creepy, I hope, or stalkerish. And then she just responded. It was really wonderful. I think people are generous and happy to help if you're very clear about what you're looking for and like the commitment involved. And, I think people like to help if they can. It turned out that lots of things happened with her personally, that it was hard for her to participate at first, and we weren't sure what was going to happen, but eventually did. And I think it's fine. And even like asking various people to mentor you on a project or to join a project, it's just, don't take it personally. Just ask. And the team is so important. So there's no harm in asking someone that you think has the skills that you need. And if not, you can ask them if they suggest someone else who has the bandwidth that could help. It's really just expanding the team so that you have all the things you need to be successful. And if it's too small, I think it can be hard to be successful.
So follow your passion and find your team. Great.
Yes.
All right. Thank you so much. We'll all do the virtual clapping. That's the one part I really miss in the virtual sphere, but I'm going to take my reactions and give you a heartfelt thank you for your time. And are there any other questions before we conclude this part of the meeting? I see a lot of thank yous. And just some comments about one, I'm struck by the multidisciplinary involvement of the various researchers you work with. Is there a department that you're looking forward to work with now?
I don't think there's a specific department I'm looking forward to working with. I'm, looking at a lot of well-being topics now. So I think more with those in that well-being space would be logical, but open to anyone. It's great. It was really cool to have someone in computer science, like totally outside of what we were doing normally, to be part of it. And I think the more we can do that, the better. It just adds more depth to our work.
All right, so everybody, you can reach out to Dr. Chrétien if you have an idea that you think would be great for interinstitutional collaboration. All right, thank you so much. So next, we have, I think it goes back to, let's see here. We manage the Q&A, and I think the next part is you, Dr. Busa.
Thank you so much, Dr. Levine, and thank you for that presentation today. So next, we are going to momentarily, we are going to go into our breakout rooms for our oral presentations today. We still have a few minutes for that, but while in the breakout rooms, our speakers will be delivering their oral presentations today. A quick note on that is that all of our presenters that you're going to hear from today, we went through a very lengthy assessment process in which we've evaluated all of our presentations today. And as part of that, we also have judges assigned to each of the rooms today as well, who will be judging all of the presentations for us today. And I'm looking, I thought I had a list of the presentations, but I think we are going to be putting that up on the screen. There we go. Our breakout rooms are going to revolve around the USMLE Step 1 examination. Many of these presentations are going to focus on the recent changes with USMLE going to a scored exam to a pass-fail exam. But these presentations will also be looking at how students prepare. As many of us know, both students and faculty know, that over the decades, primarily the last decade, a lot of changes have occurred in how students prepare for this exam, how institutions utilize this exam within their curriculum. And we can even venture to say that there's a little bit of the tail wagging the dog, the degree to which students' preparation for this exam has impacted or is influencing the preclinical curriculum in medical schools. The other breakout room that we will have is community health and well-being. One of the hallmarks of the Wayne State University School of Medicine is our mission to social accountability, our community outreach. So we have 5 presentations today that focus on community health and well-being. Following that, we have presentation on the learning environment. Again, we talk a lot about our formalized curriculum, but we also have to look at the so-called hidden curriculum, the processes, the policies, the culture around how we deliver our curriculum. Key to any educational program is our 4th breakout session, which is professional development and mentoring. This involves anywhere from professional identity formation among medical students to various policies and procedures used within the medical school and how that reflects on professional identity formation. We then have a session or a breakout on curriculum or medical training, in which we will be looking at various curricular interventions, both here at the school and elsewhere, and how that influences student learning. And finally, a much growing area and one of high importance is students' health and well-being, is looking at how our students adapt to the medical education process and looking at their health and well-being as they move through the curriculum.
So, Dr. Lipson is the immediate past president of the Society of General Internal Medicine, one of my homes. She is currently Vice Dean for Education at Columbia University's, I'm going to mess this up, Vagelos,
yeah.
College of Physicians and Surgeons at the Ralph
Schlondecker. I had to learn it myself.
Professor of Medicine at Columbia Irving Medical Center. Her work focuses on innovations and improvement in health professionals' education and assessment, health equity, workforce diversity, faculty development, medical care delivery, and provider communication skills. And yes, she works in all of those areas. In her prior life, she worked in government and including serving as the Director of Medical and Dental Education for the Veterans Administration, where she oversaw undergraduate and graduate medical education across the United States within the Department of Veterans Affairs. She's a board-certified general internist with significant leadership experience in clinical, educational, and administrative arenas. Prior to this role, she served in many hospital leadership roles at the Ann Arbor VA healthcare system, including acting chief of staff. She spent years in educational leadership roles at the University of Michigan Medical School, where she was the assistant dean for graduate education and the interim associate dean for diversity and career development and faculty director of the standardized patient program. She's a clinician educator and has published over 80 peer-reviewed publications in top-tier journals, and I've read some of them. They are really impressive. She works in the areas of resident assessment, communication skills, cultural competency in education, workforce diversity, and faculty development. She's had many roles focused on health professions education, including working with the ACGME, the Accreditation Council of Graduate Medical Education, which is where every one of you wants to be when you get a residency. They accredit your training program. She's also worked with the Association of American Medical Colleges and at the National Board of Medical Examiners. And she served previously as the secretary of the Society of General Internal Medicine. As a medical educator and leader in administrative organization and professional manners, she serves as an executive coach. She's mentored faculty and staff as well as peers in various specialties and administrative areas. After graduating from St. Ignatius and then graduating from Brown University, she received her medical degree from Case Western Reserve University School of Medicine. She completed her graduate training at the Brigham and Women's Hospital in internal medicine, primary care. Subsequently, she went on to complete a Robert Wood Johnson Clinical Scholars Program at the University of Chicago and a Master's of Health Professional Education at the University of Illinois, Chicago. She has trained to be an executive coach, and recently, because she loves education and never stops, she's entered the 4th cohort of the Aspen Health Innovator Program, and she's part of the Aspen Institute. As a strategic and visionary thinker, Dr. Lipson inspires all people at all levels to meet their goals and optimize their full potential. She's immensely committed to high quality, cost-effective care for everyone, including our veterans. She continues to strive for wellness and work-life balance. She's written on the topic of physician marriages, especially in academic medicine, and is the wife of Dr. Andrew Campbell, a pediatric hematologist-oncologist, and the mother of 2 school-age children. Dr. Lipson, welcome to our conference, and we look forward to your talk.
It's so excited to be here, and it's a hard act to follow my colleague Kathy, but I hope these talks will be synergistic in a useful way. So as soon as I get this into a slideshow, can everybody see the slides there? It'll be great. And I'm so happy to be virtually back in the Midwest, which is my home. And just to tell you the objectives, I hope what you'll take a little bit about Catherine's story a little bit earlier and really try to play around and think about formulations for success and career pathways as clinician educators. Kathy did talk about a good definition of educational scholarship, and we'll talk about actually how to think about that in your roles, either as running labs or as course directors or as associate program directors, et cetera. And I hope to give you some examples of how to develop and promote your own twofer, I guess, for the lack of a better word. And I hope to give you some examples about how having a strong goal and a value set can you can incorporate it into all the work that you do. So that's sort of the outcomes for today. I like to ground everything that I do really in the understanding for you to really understand the lens that I come from. After spending many years in Ann Arbor, Detroit felt very much like home. I'm from the South Side of Chicago. I really come from an inner city background, so much so that it's kind of funny for me to hear about issues around redlining and some of the social determinants of health, because I grew up as a kid whose grandparents lost their house as I-94 was built through the city, divided the city into 2, Bridgeport and Bronzeville, can talk about sort of the implications that has for wealth. And I come from enslaved ancestry on both sides and am grateful to be in medicine. And that is the lens that I bring to what I share with you today. And, my family is sort of who promotes me. And you heard a little bit from Diane about sort of what you might think is what's important. And I hope to show that some of the stuff about where I'm from and how I see the world is how I've informed many of my decisions about roles and career choices, but also a lot of my educational scholarship. In full disclosure, my parents were Chicago public school teachers. They taught in inner city Chicago. And my mother once told David Leach, who ran the ACGME, that she didn't understand why medical education was taking so long to get to competency-based education, because she was doing it in the 60s in inner city Chicago. So understand that's the lens in which I sort of started my work within medical education. So because it's late in the afternoon, you're going to have to do some work so I can make sure I can wake you up a little bit before dinner time. And so if in the chat, as we think about building a successful career, what are some of the things that you think people need to think about as they build a career? And I'm sorry, I'm going to have to share my chat box here. So we've got charisma, we've got grit. I wish we could figure out how to select for grit. Equal access to opportunity, right? So talent is ubiquitous. Opportunity is what's is often segregated. Networking, I'm going to talk a lot about that. So this idea about one of the problems with equal opportunity is that really you want equal opportunity to networks. Growth mindset gets back to that grit and listening skill, mentorship. And as I get along in my career, is that mentorship? Is that coaching? Is it sponsorship? Focus on patient outcomes and the experience, right? So if we hear that's backwards design and education, what's the outcome? And then we can build the program and the assessment structure, lifelong learning. So what keeps me engaged? I think if you ever lose the desire to learn, you're going to do that. So great. So thank you for taking some time there. And there's some data out there about some keys to building a successful career path. And one is having a purpose, a vision and a goal. So kind of goal setting is the best way to sort of think about that. So, what is your purpose? Having a clear vision of what your outcomes want to be. Developing knowledge, skills, and attitudes, and now competence is part of that. Having mentors, so having career mentors, and we'll talk a little bit about that. I'm a big believer in a panel of mentors. There's people who have been really helpful in thinking about my educational research, but then there's people who've been helpful. You heard from Catherine, when I was parenting, I reached out to a lot to her, sort of thinking about how to be a good enough mother. Networking skills, which I think is one of the key issues that we often don't really talk to our trainees and junior faculty about enough. And then expertise in career. So really learning about what it takes to be expert in your career is really sort of key. So here, one of the outcome measures of success for clinician educators, and that's what I'm going to talk mostly about today, is this idea about promotion might be one of those outcomes that we can think about. So now we're going to think about how to align preparation for the promotion. Now, whether you're thinking about that as a trainee, like, oh, I think I want to do academic medicine and I want to teach. So how might I shape my career? You might be thinking about this in an assistant professor. How do I get to an associate professor? Or you might be an associate professor thinking about how to become a professor. And I think even I think about, so what might I want to do? And when I grow up is still a question I have on the table. So promotion is really one of those things that ideally recognizes excellence. It's often measured by scholarship and reputation, and that's what we're going to talk about cultivating. And there's this real acceptance that the timeline is long, and we need to prepare along the way so that we're successful. And I learned this from Margaret Getko at University of Michigan. And when we talk about education and scholarship, and I think Dr. Crichton gave us a nice example of her 3 stories and papers about examples of scholarship. And for those of you all, and I heard, we had talked a lot about sort of HIV treatment and all of the innovations that happened at Wayne State earlier, it's not any different than when we're talking about research. These are just two terms that are synonymous. And basic science research, if we wanted to define, is the scholarship of discovery, versus often what I do is the scholarship of integration or the scholarship of teaching and learning. So there's just different types of scholarship. Research is just one of those. But I think some of us often think about it's this time of year and we want to think about Charles Dickens. And, you know, there's a Tale of Two Cities, and it depicts the plight of French peasantry under the demoralization of the French aristocracy. So you might think of that as, you know, on the Wayne State, it's the research educator or the clinical scholar. Those are the folks who can get tenure. In my world, that's professor with tenure. And then there's corresponding brutality. We know all in the Tale of Two Cities about former aristocrats and unflattering social parallels of life. And then there's the protagonist of events about who might fall victim to the wrath. But we also might have that as we think about the educational track faculty might be thinking of themselves as the demoralized peasantry. And those might be the clinician educators, the adjunct professors. In my world, that's the professor at Columbia University Irving Medical Center. And I hope this talk will sort of help you work through some of these lives, and you can hear where there's sometimes where I fall and pray. And then you heard the story of overcome, but I don't want you to think that it's always like that. And here on this slide is an example. You can take you right to the Wayne State promotion and tenure guidelines. But what I'm really excited about and trying to coach people with is sort of thinking about everything they do in a twofer. Sometimes you can even get a threefer. And that is really this idea of, as put forth here, to become a twofer leader is about trying, as a general rule, to feed two opportunities or identify things well done for every problem you're working on or trying to solve. So you're always trying to create win-wins, even if little ones. So if you're being hired to run a course, how can you get some meaningful scholarship out of that? Right? So you're going to get paid to do that course, or you have some time set aside to do that course, but part of your own personal development, we want you thinking about promotion in that realm. And here's two examples. This talk is not out of whole cloth. I think I started thinking about what does it mean to think about your own career development when I was a fellow. This is literally the slide that created when I was a Robert Wood Johnson clinical scholar. And we called this slide Finding a Job or Prostituting One's Soul. I was young, used my sorts of terms. And because what I found was I got a bunch of us, my peers together, and we started to peer mentor each other about how to find a job, because we felt like the information out there just wasn't clear. And then eventually I took that and developed, when I became an associate professor, literally the next year I was thinking, okay, well, what do I need to do to get to the next role? And so I developed a course that we put on at the Society of General Internal Medicine, and I pulled up a junior faculty member from Rush at the time, and we created an award-winning workshop at this meeting. And it was really, you know, it wasn't all altruistic. I wasn't just trying to put on this meeting for an annual meeting. I was trying to hear from the people who had already made professor, and sort of how, as clinician educators, and thinking about how I could sort of role model. So that was really helpful in me in getting a jump start in moving and thinking about how to move from associate professor to professor. There's this great paper, and the QR code is down in the middle, by my friends Anna Chang out at UCSF and Alicia Fernandez, where I think this is probably the best paper out there if you want to think about options for an academic clinician educator career. And it tells you about the multiple paths that you can have as a clinician educator. You can be an educational researcher. I think I saw Brent Stansfield on here. That would be somebody I would think about that. You can be an educational leader, someone like Dr. Wayne. You could be a clinical leader, or you could be a master clinician educator, where, you know, trainees and patients come to you all at the same time. But this paper takes you through some nice frameworks about what you should be thinking about at each stage of your career and the timeline between, say, 1 and 7 years going towards promotion. And these criteria are pretty ubiquitous no matter what institution they are. They might have some quick turn of phrase, but here's ones from BU. And the criteria that's often considered by a committee is, how do you develop an area that you call your own? How do you think about dissemination? And you know, 20 years ago, that was really about peer-reviewed publications. I'm glad that the field has become more generous, but dissemination really is key. You know, how do I make sure that the curriculum that I developed might not just be useful for me in internal medicine, but have they adopted it in surgery? Or better yet, have they used it at another institution in internal medicine? And then evidence of peer review is really the sign of scholarship. And again, it doesn't have to be in the classic peer review publication, but, you know, have you had your colleagues come and watch you teach on rounds and giving you feedback for the evidence of your teaching? So as I talked a little bit about before, just to walk you through the definitions of scholarship, and here's some examples. So there's the scholarship of discovery. So this is really for the medical education researcher. You have an idea and you're going to implement that and discover it. I think you heard 2 examples of that from Kathy a little bit earlier today. But here's an example. We developed secret shoppers, so secret standardized patients that went into resident clinic at the VA in Ann Arbor and in Cleveland at the Cleveland VA to really assess, could residents pick up military psychosocial trauma and PTSD symptoms in a patient presenting in a psychosomatic type way. Another example would be the scholarship of integration. And so I pulled one of Catherine's papers where she talked about, her interest in blogging, but she's had a long career in thinking about sort of media vehicles along with diversity, equity, and inclusion. So here's an example of her paper looking at kind of a systematic review of websites. So that's something you can do. That's the scholarship of integration. There's the scholarship of application. So last year's keynote at this meeting was by Lou Pangaro, who has a storied career. And he has lots of examples in his work of scholarship of application. And this is just one of his papers talking about how do you test a tool and ensure it's valid in different settings. So using the mini CEX, and this paper was this is a kind of a classic paper from about 20 years ago. And then finally, there's the scholarship of teaching. So Christina and I with Javid worked through, here's just some teaching tips on how to teach about implicit bias recognition and management. So how do you disseminate that around curriculum and cultures? So these are things that your committee, if you think about promotions, are going to think about. And then the other thing they're going to think about is, okay, do you have a reputation? Is that reputation within the walls of the DMC? For many of you, is that regional? So in Southeast Michigan, or say in Northern Ohio, is that where your reputation is? Is it national and then international? And there's several ways to sort of think about that, and that's how a committee might do it. But you're saying, hey, Monica, I'm a clinician educator. How am I supposed to think about that? And I want you to think about the concept of generating social and cultural capital. And I think, we think about capital, we often think about money. Marx was the first person to start to talk about sort of capital and capitalism. But, the sociologists over time have thought about other mechanisms of capital, be it human capital, cultural capital, or social capital. And these are the things about building networks. You saw about this, creating trust and belonging. How do you acknowledge power, privilege, and the power of resistance? What we see amongst many of our students, and I say we should harness their power of resistance. So these are ways that we can think about developing this capital, but it's the social and cultural capital that often clinician educators really have to work to build to do that. And so networking is the classic example. And you heard a little bit about sort of, as I thought about sort of national presence, I just started as a resident going to Society of General Internal Medicine. I was part of the Disparities Task Force that over time became the Health Equity Commission. I have always and continue to be a member of the Minorities in Medicine Interest Group. I've been on multiple program committees and then went on to leadership within the society. But then there's focus within the society around education, around anti-racism, assessment, workforce diversity. So doing that in a national societies, and if you're not an internist, you might be doing that in the American College of Cardiology, you might be doing that in otolaryngology, but all of our specialty societies have a mechanism for you to develop networks of other like-minded individuals, but also a way to develop your national presence. And so here's the example I gave before. This is literally taken from my educator portfolio. And in the portfolio, I talk about sort of participating and doing this clinician educator workshop at SGIM. It won 2 awards, one for me delivering it myself, and the second supporting a junior faculty, and what those scores were as a way to demonstrate that. So let's sort of go back to the chat, make sure everybody's still awake. And I'd like everybody to, oops, that's the second example, list activities that you participate in at a national or regional level. So just list activities. And some of this is just to get your juices running about sort of how you think about some of the work that you do. No one has regional or so Diane is in CDIM and SGIM. Brent talks about sort of national conferences, going to those. Any others out there? So those are ways that you think. So grant writing, right? So mentorship, the NAACP, the AAMC. So these are all places that you, believe it or not, are developing your national and regional reputation. You know, the oncology initiative, I wonder if that's the quality oncology. So both in pediatrics and internal medicine, they are huge, rich collaboratives that not only talk about improving patient outcomes, but often are places for CME and other educational development and other presentations. So I want you to think about when you go to national meetings and you participate on national committees, you actually are doing career development because you're thinking about your national, regional reputation. Because the second part of this, and I gotta put you on gallery view. I'd like everybody to give me a reaction. You can use any of the reaction tools as long as they're tasteful. And tell me if you can think of 5 people who could, if your chair or supervisor reached out, could write you a letter of evaluation. So just put some sort of reaction up in the on your screen to say, can you think of 5 people who could say lovely things about you? So thank you, Joseph. Are you the only one out there that's got 5 folks that could vouch for them? There we go. Aaron. Aiden. So I encourage you, if you ignoring me, that's okay. But if you also are finding that, oh, I can't name 5 people, that's something you want to work on. You want to be able to work on so that when it comes down for promotion, when you apply for fellowship programs or you apply for faculty roles, that there are 5 people who, if unsolicited, Monica Lipson called them up, could recognize your name and with some prompting, i.e. maybe your CV and maybe your educational portfolio, could actually detail and write a letter of evaluation. Those are the things that you need to sort of think about promotion. So almost every school, this is an example from University of Miami in Florida, request somewhere between 3 and 15 letters of evaluations from people out the outside. They ask them to review your educational portfolio. They ask them to review your CV. These are all things that is done as part of the promotion process, but I want you to take control. You can't control this part, but you can control the part about making sure that people have enough breadth and knowledge about what you do every day. So here, excuse me, I don't want you to think it's been a cakewalk. So, people, you heard a nice intro and it sounds like Dr. Lipson had a lovely career and it just kind of goes up. And I can tell you all the pitfalls and the problems as we think about careers. And I'll give you some examples of where I let some of the lows and really some times of struggle really kind of prompt my scholarship. And just like Dr. Crichton talked about sort of what prompts asking a good question, sometimes I let me wallowing prompt a good research question. So this is one of, I guess, one of the papers I'm most proud of, and one of, I think, has really contributed to the literature about thinking about critical consciousness, social justice, and medical and multicultural education. So you notice these terms are from 2009, well situated in the sociology literature, but became really ripe ideas in 2020 after the murder of George Floyd. And so this paper with Dr. Kumagai Arno, who's now in Toronto, really came out of me leaving maternity leave with my first child and the dean coming back and saying, Monica, you don't have enough publications to get promoted. And I was devastated. And I was in the office talking to Arno and I was saying, I need papers, like literally, to get promoted at this time to associate professor. And so we talked through some ideas, we threw around some ideas, he had some things cooking, and this is the outcome. And if I hadn't said I was suffering, I don't think he would have necessarily brought me in as a junior person at this time about one of these profound papers. So that paper, which is actually my most highly cited paper, really came out of a despair point. Another point, this paper, which I wrote as a member of the editorial board of academic medicine, and that eventually now has prompted me to be an associate editor on the journal, but really came out of my own personal anger with the events of 2020, the murder of not only George Floyd, but Sandra Bland and Aubrey and others. I didn't realize how angry I was until I sat down to sort of help lead the writing on this editorial in the summer of 2020. And it was actually quite therapeutic. So sometimes when I talk to our junior trainees and specifically the medical students who I serve at VPNS, and they're angry about the state of situations, I tell them to go write, because not only is it therapeutic, but it can contribute to the literature in a meaningful way. So again, if we want to think about this twofer, I'm going to give you some examples in the rest of the talk before we open it up for questions about sort of how to think strategically about this in everything you do. So many of you all might have administrative roles. You might be course directors, assistant clerkship directors. You might be the educational lead on a grant. That's an administrative role that you are expected to have some deliverables for. But what you want to do is think about that role and then how you can leverage that in the other domains of what you might be thinking about a career. So if you are an assistant clerkship director, and again, I'm using internal medicine, so CDIM, which is the clerkship directors in internal medicine, or if you're in pediatrics, COMCEP is where the pediatric clerkship directors, that might be where you go to develop your work. And you know, you're going to that meeting to try to be a better assistant clerkship director. But again, we talked about leveraging that to improve your regional and national reputation. I gave you some examples from Society of General Internal Medicine. So you want to think about that. And then when you're thinking about your administrative roles, you also want to think about scholarly inquiry. So how can you collaborate across peers? So if you're a course director in the pre-clerkships, how might you collaborate with course directors in the clerkships? Or how might you, if you are a basic science course director, how might you collaborate with the clinicians to improve your course? That's a pursuit of scholarly inquiry. You know, I am not one to champion the cause of the LCME accreditor, but we should use them when we need. They give us in standard 1 a nice incentive for improvement. So you could use the CQI to improve your course. You have to do that anyway. Why not make that scholarly? And it might be cross-discipline or cross schools. There might be something that the medical school is doing that can work in the nursing school, or there might be something that the medical school and the nursing school could do that's working really well that actually the school of social work has perfected. You want to bring those collaborators in. And then I wanted you to talk about professing for purpose. So this idea that you have a goal, and so we all have to profess if we're in academics. Some of that we're paid for and not, but I always thought about equity and justice as part of everything that I do. So even if I was talking about hypertension management, I would always think about that from an equity lens in the VA. How do we make sure that our veterans who identify as Black and Latinx have the same outcomes of their hypertensive intensification of medicines as our white veterans? And then another thing is you want to know what they need to know before they need it. And that is a place where you can lead in terms of being novel and innovative. So here's 2 examples of, I had a role as the Assistant Dean of Graduate Medical Education. At Michigan, we developed one of the first hospital-based OSCE, and that's probably what I'm most known from nationally. And we figured out how to assess those early competencies as they were rolling out, and started that whole conversation about what is that transition point between UME and GME, because we were finding gaps at the time of, start of internship, that the medical school wasn't as transparent about sort of either educating their learners or telling us about it. But that went on, and that was a very successful part of line of inquiry. But in the back of my mind, I was like, how could I be thinking about competencies and this use of a clinical assessment tool to really improve the diversity of our GME applicants and matriculants? So here proved that, almost a decade ago, that actually you could forgo a little bit of this emphasis on step 1 and step 2 scores, because overall, when we were looking at clinical outcomes or the things that interns had to do every day, there really was no difference in the interns entering University of Michigan over the course of about a 4 to 5 year period between those who had been historically underrepresented and those who are not once you took out board scores. So that's a labor of love. No one said I had to do that, but that was where I thought I could push the field to really think about how they might assess. Another outcome that wasn't sort of this idea of just doing the OSCE for patient safety and meeting our Joint Commission requirements, I was like, how do we give feedback to our schools? And so one of the interesting things is each one of these little dotted lines is a different medical school. And we have different pieces of outcomes here. And I can tell you each school on here, and it's an interest representative. And so I'll tell you the one that we've made public. The University of Vermont is sitting right up here at the top. And is one of the top schools. It's not one that you often hear about if you're sort of thinking about, but I will tell you any day if you're trying to hire a resident or a faculty member and someone graduates from the University of Vermont, I would go after that person because there's something that they do at the curriculum base that definitely promotes excellence. Here's another example of trying to do faculty development for an entire committee. So I was also an editor when JGME first started and found a way to develop a section with Deb Simpson and got the whole internal review or special review committee on as an advisory goal. And it was one of the ways as a dean, I could do some faculty development for an entire committee to help them sort of help us develop this section of the journal. So again, this is a twofer. So I had to do the special review. I had to be ACGME ready, but then, part of the ideal world is I'm doing program director development. So that was one way. We needed to do some scholarly inquiry. So that was a way we collaborate with peers. You have to fill that out in web ads about how much scholarship faculty are doing. And then profess with a purpose. So as we were thinking about program director career development, one of the outcomes that we hadn't thought about was many of those people became members of the RRC because they had some expertise that we had highlighted for them nationally. So they could become experts in their field. Another example here, and just to run you through before we end, is, as the multicultural curriculum director, again, you can see how words change over time. I ran this thread at the University of Michigan for about a 7-year period. And again, it was a course directorship. It was a longitudinal career, but I actually used it to really help me think about equity, social justice in the curriculum. How do you teach about that? How do you actually get faculty prepared to teach about that? And then doing that in terms of publications, presentations, both nationally and internationally. We have colleagues across the world who struggle with the same problems we do. And there's meetings where we could present our work either north of the border there for you all, right across the bridge, or across the pond at Amy in the Atlantic. And these are just some other examples. The other thing that I've sort of been interested in, and you heard a little bit about this from Dr. Crichton as well, is how do you use art? I found myself talking about race and racism in 2006, running that curriculum thread when it wasn't as easy to say those words out loud. And one of the ways that I was able to do that is to use art, because art is often a mirror to what society was thinking about. And so I don't know if you recall, or anybody here is old enough, Crash won the Academy, the Oscar for Best Picture, but it was really a picture about race and racism and the interaction of the world. Also, Avenue Q had won a Tony in 2006. And everyone's a little bit racist, was the sort of catchline song from that. And so I found ways to use those as triggers to talk about really difficult conversations within medicine. But to have that in a way. And then one of my favorite books that everybody should use, it's Red or Blue, I Like You, is a nice Sesame Street book. And the hidden message is there really about race and inclusion, even on Sesame Street. And then those are sort of curricular examples, but then at the VA, we talked about even bias that our learners and ourselves have against veterans. And we did a project called Service Transformed, where we had professional photographers go in and take pictures of veterans in their home and see did that change people's perception of the veteran they were taking care of. And we would juxtapose that to pictures when they were in service. And this is from a Tuskegee Airman from Detroit. So again, this idea of a twofer. So you've got an administrative role, the curriculum director, multicultural curriculum lead. You have to do a longitudinal curriculum. There's some risk there. So how do I think about career development and sustainability? So that's where I got involved with other national committees, worked with the AAMC as they were pulling out the TAC tool and talking about cultural competency, so that I could have some support when I was putting forth very controversial issues. This is important for those of you all who are working on anti-racism now, because there's a little bit of a backlash, and having the support of the AAMC and the DEI competencies is part of what helps buoyant your work. And then there's the scholarship for inquiry and art. And again, you want to profess for purpose, what's the national movement, understanding what you do. So let's give a few examples in the chat if people can think of how they might have thought about a twofer. So an example where you might have a role and how you might use that for scholarship, or how you've had a committee role and that sort of helped you with your national reputation. Oh, good. So micro rounds and then being APD. So then you could think about, and then how can I do scholarship? Student ideas for course improvement are fertile work for scholarly work. So exactly, sort of really taking what you have to do anyway. And one or two more steps might have a huge deliverable for you. And one of my favorite examples is similar to the stories that Dr. Kuyten talked about before. There was a second year med, so I was fortunate enough, I'm an old lady with young children, and I had both of my children basically in front of the medical students at the University of Michigan, and my husband worked there, so they could see us, they could see the nanny handoff, they could see us sort of migrating. And one of the students one way said, I saw at the grocery store and they asked me how I went grocery shopping. And I was a little insulted because I was like, do I look that bad? Like, I got in the car and I went grocery shopping. It was Ann Arbor. And they said, no, Dr. Lipson, I don't understand how you go grocery shopping. And I was like, I get in my car and I go grocery shopping. And they were really asking a more profound question. And we used that work and we developed a medical marriage selective where we had physicians talk about how they navigated work-life integration in their lives. And after we did that is like kind of 2 little small symposiums for second years before they transitioned, we said, hey, maybe there's scholarship here. And so we interviewed physician couples. Some of them were dual career couples, dual physician couples, some were not. Some were heterosexual couples, some were homosexual couples. And we really came up with some themes about how they made their marriage succeed. And they talked about mutual support, shared values. The reason I'm going to spotlight the same-sex couples is because their discussion it's where I learned most about how to navigate role clarity within my marriage. So when you're unable to fall back on gender norms as a unstated expectation, you actually have to talk about who might do a certain activity in the house. And I found listening to my colleagues who navigated that in a same-sex relationship incredibly insightful as to ways and tools I could take home to me about how I could use that for role clarity in my role. So this was really driven, and this whole line of work was driven by a student question about how do we make medical marriages succeed. And I bring that to everything I do. So the family is front and center to what I do. So I really hope this time talks about the twofer. So again, if you want to think about developing a career, you want to think about developing what are your core values, because those are what you want to stay true to. And then you want to seek advice, coaching, mentorship. And you want to have a firm understanding of your skill set. So I can tell you just as much about what I'm really good at as I can tell you about where my areas of improvement are. And I really use a strength-based approach, and I really try to enhance my strengths. And I just make sure that my flaws are not deadly. So example, one of my flaws is spelling and grammatical errors. So I just hire people, my executive assistants. You can't be my executive assistants if you can't help me edit. And so my mother, the language arts teacher, thought that I could get better at that. It's been a deficit. So this idea of knowing where your skill set is and then how you can help mitigate any issues with that is critical. So this is how you would want to think about career development, and how I hope the twofer let you really sort of think about this and become an expert, whether you're a clinician educator or a clinician researcher. I think these are things that as we really focus on the need to consider well-being and preserve our strength, the twofer is really the way to go. So I'm happy to take questions, and I appreciate your time and patience.
Thank you so much. That was a fantastic talk. And in the chat, I have at least one question, and that is, will you be able to share your slides? There are some wonderful links that people are interested in looking at. So with your—
Yep, I will send them to you a little bit later. Yep.
Okay, that sounds great. I wanted to make one comment, and then if people can put questions or comments in the chat, we'll address them. I just wanted to say, I think thinking about what you profess and what are the opportunities to twofer, they apply to our incredible medical students who have administrative roles as directors of student groups or members of faculty senate or people who are participating in student-run free clinics. And I think that there are opportunities for our students to join national committees. Every committee I'm on, I say, can we have a student on that committee? So at SGIM and the Patient Safety and Quality Improvement Committee, there's a student. At the Amy SIG for patient safety, there's now an opportunity for a student. And then also, this is a great way to begin your dissemination at this conference, but take it to the next step. Take it to the next step and disseminate at regional and national meetings, because what you do is valued. And I think the advice that Dr. Leibson said today can be applied at the beginning. So lots of comments that it was an excellent talk. Thanks for sharing an inspiring talk.
So there was a question. So I couldn't agree with you more. So I got started on national reason because I said I was the first. So here, this will tell you how old I am. My class is the first class that took 3 steps of USMLE, right? So they weren't on the computer, but we did take, like, I was the first cohort that took step 1, step 2, step 3. And I was the first student that the NBME had on the USMLE Step 1 committee. And it's where I met Jim Woolscroft, who became dean at Michigan. And I remember as a student, I'm going to go and tell those people in Philadelphia that they're idiots. That was sort of my resistance. And you can say whether or not I was successful or not, but it's imperfect. And then another story is just we have a group called the BALSO, which is the Black and Latino Student Organization. It's an umbrella group for both SNMA and LNAMSA at Columbia. And they've been together. You're still members of SNMA or LNAMSA, but they're under BALSO. And they were talking about, should we separate it into two groups or should we not? And finally I said, well, here's a perfect thing to write about, guys. As you all deliberate this as a student group, I think this is an interesting question because there's no right answer here. And as we think about promoting equity in our affinity groups, I think the idea of should we be together or apart is an interesting conversation. So that was just the conversation I had with them about 10 days ago. So you're right, students getting involved with that. And there's a question about medical marriage and measurable work. So I have had 2 papers that I've written with my husband, and there's a reason why there's only 2. So that's one thing that you can try. We worked on some patient narratives. He runs a sickle cell program at Children's National. And so I was really interested in how patient stories can teach our medical students. So we worked on 2 papers together. It worked out fine. We're still happily married. I was not going to work on a 3rd paper with him. So one option is there might be places where you could work together. So that's one. The other way was we both support each other in our scholarship. So I guess as a woman with small children, I'm actually in Colorado right now. Diane knows this in an SGIM meeting. And, my husband, it's a conversation. I haven't been limited about childcare because of a frank conversation we've had about the need for dissemination of both of our work. So I'm gonna come home and he's gonna go to American Society of Hematology. We actually won't see each other. The kids will not have a parent on the ground for about 10 hours where I show up and he goes to New Orleans. But there's a conversation in they're old enough, they're 11 and 16, they'll be okay. Where we can
don't need that. Child Protective Services. Right.
So, and my in-laws are there, so don't get too freaked out if this is a recorded call. But so there's a way that we do that. And then the advice about thinking about descriptive work, I know you all had submitted a survey from COVID about how the implications of COVID were having on faculty who identify as female and who had children as that. So really taking those questions and those burdens that I think we all are having in our lives and trying to use them in scholarship is helpful. And I've just sort of used that strategy. So I hope that answers that question. And then there's a question about witnessing arts and humanity. I think we're coming to realize, so you heard from, the world of Osler outside of Dr. Crichton earlier. It's virtual, medicine is an art and it's very heart. And I think we're realizing this as our scientific advances go forward, we are realizing that we need the arts and humanities to actually make sense of a lot of our technological innovation. And I think most medical schools are taking that work really seriously. I live in the world of Rita Sharon, so narrative medicine is sort of front and center in everything that we do, and it's sort of it's part and parcel of how we teach our medical students. So I agree with you, and I think we can all do more, not because most of that is focused in the pre-clerkship curriculum, and probably it might have its most bang for its buck in GME.
Yeah, great. Great, thank you. Are there any other questions? I think at this point you can feel free to unmute if you wish. All right. So I want to thank you so much for sharing. I think we're all inspired, and I hope that the people who are early in their career now have a little better idea of how they might organize their activities and do a twofer. So thank you. All right, Dr. Busa, are you available? Do we have any announcements to make?
I am always available. And our announcements, yes, we are now going to pivot to the next part of our presentation, which is our award ceremony. And so now I would like to introduce Mr. Robert Reeves and Ms. Jenna Carter.
Hello, everybody. I'm going to go ahead and share my screen for our award ceremony. So yes, first I would like to thank everybody who not only came to present our oral presentations, but also put together posters for our poster presentations as well. A note about poster presentations, so awards for those will be coming out next week. We have our judges going over those now. I would also really like to thank our keynote speakers, and then also everybody who came to listen and participate in today, and then also everybody who was part of making this happen. My name is Jenna Carter, and I am a MD PhD student here at the School of Medicine and our student facilitator. Okay, so for learning environment, I'd like to give a big congratulations to the authors of Communication Issues within the class of 2024 and 2025, Due Administrative Action, COVID Causes, or Just a Sophomore Slump. Thank you to our authors and congratulations. For curriculum and medical training, congratulations to Dana Nazar on Not All Fun and Games, Gamification of Child Abuse in Medical Education. Congratulations on your award. For students' health and well-being, congratulations to our authors for Fertility and Family Planning, the changing concerns and perspectives of physician trainees. For step one pass-fail, the impact on Wayne State School of Medicine and opportunity for change. Congratulations to all of our authors who contributed to that. And then for community health and well-being, On Call, an innovative solution to reduce language barriers in Detroit Free Clinics. Congratulations to our authors. And for professional development mentoring, congratulations to the authors of The Formation of an Independent Medical Student Admissions Interviewer Committee. And finally, we would like to give recognition to some of our faculty, one of our faculty members, Dr. Jennifer Mendez. We have a lot of outstanding faculty who do a lot to facilitate faculty-student research in a lot of these areas, and you'll notice a lot of the same names on the slides. So there are a lot of you who contribute, and we couldn't do a lot of this research without you, so thank you so much. But a special big thank you to Dr. Mendez for her contributions to supporting students to do this research.
I'm not going to provide the final parting comments. I'm going to leave that to Dr. Levine. But what I will like to say is I would like to thank you, everyone. I would like to thank our two nationally, if not internationally renowned speakers. I know I personally enjoyed their presentations on both what I would call life lessons and career development. And I think it's a really important message for us all, because regardless of where we are, whether we're students, whether we're faculty administrators, no matter where we are in our career development, professional development is a lifelong commitment. And I know personally, I resonated with both of their presentations, and it made me think a little bit about where I'm headed and what I'm doing as well. So thank you to both of you for your presentations. I would really like to also thank our students today. one of the amazing things, and when I think one of the most amazing or innovative things about how our Wayne State University School of Medicine approaches medical education research and innovation is it's student dominant. We rely on our faculty, we rely on our administrators, but we're here to support our students. And I think that really makes it really exciting and really innovative. Lastly, I owe a huge debt of gratitude to Dr. Diane Levine, Mr. Robert Reeves, and Mr. Matt Guerin. For those of you that do not know, the school is going through accreditation. We have our survey visit coming up in April. Our DCI is due in January. I am
Sleep deprived.
sleep deprived. Otherwise, I'm not engaged in many aspects of the school at this point, except preparing us for LCME. So, Drs. Levine, Mr. Guerin, and Mr. Reeves really did all of this themselves. They've done a tremendous job. I wish I could have had done more to support them, but as I learned today, I think this conference was our most successful ever without me. I'm not making any type of correlation or causation. You can make that yourself. So everybody, please thank them when you see them in the hallways or in the clinics. They really made this a success. And I would also like to thank all our other support staff as well. I know Jenna's here. Jenna always does a great job, and we have several other support staff, which I'm going to ask Dr. Levine to thank as part of her final remarks. I will give her that honor this year.
Yeah, I want to.
Or she's earned it, deserves it. I'm not giving it.
I want to also thank Elizabeth Kulski, and who has helped us with this run of show tremendously. I think that Robert Reeves walks on water. He has really spent a tremendous amount of time at every stage. The only thing is he deserves 2 salaries, as does Jason and Matt Guerin, because they need to clone themselves. And I really am indebted. I was concerned that we wouldn't be able to pull this off, but man, those people are holding this on their shoulders. I also want to just take a moment and reflect. This is an incredible opportunity where students presented their posters and their oral presentations. I want to encourage you to take it to the next step. We've been pushing meetings like the Society of General Internal Medicine, previously with the Society for Hospital Medicine. I post things related to internal medicine, but there are lots of opportunities in every field. And all of us in medical education, we want to see you successful. You are successful today. Reach out and we will help you with your submissions to regional, national, and even international meetings. And there is support from our School of Medicine and our incredible Alumni Association. So take it to the next step. It'll make you more competitive for your next step and is part of building that academic career. And I want to thank everybody for your time and attention, and to our speakers, Dr. Leepson and Dr. Chrétien. We loved hearing your stories, and I hope everybody here will add their own story to academic medicine and be able to contribute to the body with their values and their passion.